Assalamu alaikum. Thank you for coming. أنا الأستاذ الدكتور محمد العاني، استشاري الباطني وأمراض الدم، وأدير عيادة أمراض الدم في مستشفى الأمير علي بن الحسين العسكري. Today our lecture is going to be about approach to anemia. So what is the definition of anemia? The World Health Organization define anemia as hemoglobin level of more than 130 gram per liter. There are two type of units, 130 gram per liter or 13 gram per deciliter. So if you see it in any books, don't be confused. In men, and 120 gram per liter or 12 gram per deciliter in women. This difference between men and women is due to androgen, because androgen stimulate more erythropoiesis than the estrogen. The critical element of erythropoiesis are used for the initial classification of anemia. What we mean by erythropoiesis, that if the bone marrow is hyperplasia, that there is increase in the production. When there is a hemolytic anemia, there is increase in the production to compensate for the loss of blood loss. Or there is an aplastic anemia, when there is suppression of the bone marrow. So you take these into consideration. So to start with, when we see a patient with anemia, as we will learn from your next year, we start with the history. We take history from the patient. This is very important. At the age of the patient, if the patient is young age group, most likely the anemia is going to be inherited, like hereditary spherocytosis, hemoglobinopathies. But if anemia occur in elderly, one of age of 60, then the cause is mostly acquired, either nutritional or there is a bleeding in female menopausal, postmenopausal, or in men gastrointestinal bleeding. Is this bleeding actively or in the past? How we know that it is active, the bleeding is active? First of all, the history, the patient tells us that he has vomited the blood 2 days ago. And this vomiting of a blood is either fresh blood, which occur when there is dilated esophageal varices, or it is through the rectum. The color of the blood will be tarry, زي الزفتة, tarry, black, stool, offensive, and shiny. We call it melena. So if the patient has melena or hematemesis, and the last few days, then this is a recent one. Also, when the patient has hypotension, this means that the patient is losing blood volume. So the patient will develop hypotension. But if the patient is not hypotensive, the bleeding. Wa alaikum assalam wa rahmatullah wa barakatuh. أهلا وسهلا. The next thing is to look if there is any evidence of RBC destruction. What are the evidence of RBC destruction? It's that the patient is jaundice. So jaundice is evidence that there is an RBC destruction. Is this the bone marrow suppressed? From the history, from the clinical examination, how would you know that the bone marrow is suppressed? When the patient become pale, plus decrease in the platelet. This platelet manifests as subcutaneous bleeding, purpura, we call it. We will see a few of the slides. Or the patient present with fever. The fever is due to neutropenia. When there is decrease in the neutrophils, the patient more susceptible to develop infection. So is there is any evidence that there is a bone marrow suppression? Is the patient nutritionally deficient? History, the family tell you that the child is eating clay, tarabu, teen, or he is taking that slough from the wall. This is called pica. or PK. Past medical history, including medication review, toxin exposure. What are the medication that is important to patient with anemia? The most important is the non-steroidal anti-inflammatory drugs like diclofenac, Voltaren, ibuprofen, aspirin. This will cause gastritis and might lead to GI bleeding. Toxin exposure, patient exposed to radiation, isotopes. This also gives you an idea about the past medical history. Now, once you see the patient with anemia, then the first step is to do a reticulocyte count. As you know, reticulocyte count is between 0.5 to 2.5% of the total RBCs. And it's the last premature stage in the bone marrow before it is released to the peripheral circulation. It is increased when there is bleeding or hemolysis. أنا أشبهها دائما زي من تصير بحرب وكثير من الجنود يموتون يروحون يجيبون اليونجر ايج جروب اللي عمره 16 و17 و15 يخلوهم كجنود بالحرب. The same is here. When there is destruction, then there is a premature release of the reticulocyte to the peripheral circulation. But we should not take the absolute number of the reticulocyte granted. We have a formula called corrected reticulocyte count, and this is corrected to the hemoglobin of the patient. نقدر نشوف ده تسجل ولا لا؟ على جروب ايه؟ جروب ايه؟
ممكن انه مش طالع الناس يعني. لا في ريكوردينج
بس هو ما يطلع عندكم
هو مش طالع عندي
غريب.
ما هو
طالع عندكم شباب بس اريد اتاكد
تحت هيك زي التطبيقات يكون يطلع
اريد لو لما اخلص يلا يطلع
ما نشوف ميتينج اوبشنز
ممكن اول شيء
انا مبدئيا خلينا ممكن نحاول نعمل يمكن شو أولي
Okay. Okay. Thank you very much. Thank you. So, sorry for this interruption. What is corrected reticulocyte count? We take the reticulocyte of the patient, we multiply it by hematocrit of the patient, divided by 45. What is 45? 45 is the normal average hematocrit. You can use the hemoglobin, the same. But instead of 45, we use 15. Because 15 multiplied by 3 would give you 45. So you can convert the hemoglobin into hematocrit or hematocrit into hemoglobin by multiplying hemoglobin by 3 or dividing the hematocrit by 3. So let us take an example. If the reticulocyte of a patient is 3, which is high, and the hematocrit of the patient is 30. So 3 by 30 equal 90. Divided by 45, it will be 2. So it is normal. So you should take the corrected reticulocyte count rather than the absolute value. Excellent. Thank you very much. So according to the reticulocyte count, we can divide anemia into hypoproliferative, when there is decrease in the production in the bone marrow, or hyperproliferative. What are the causes for hypoproliferative? It is iron deficiency anemia. There is no material to iron to synthesize or to produce RBCs, B12 deficiency and folate, a chronic disease like patient with rheumatoid arthritis, patient with tuberculosis, patient with chronic osteomyelitis. These are chronic disease, also cause hypoproliferative. Sideroblastic anemia, aplastic anemia. When we say aplastic, this means that there is a suppression of the bone marrow, whether it is due to autoimmune or due to drugs. And myeloproliferative disorder اللي هي تشمل البوليسايثيميا روبرافيرا, essential thrombocytosis, primary myelofibrosis, and some authorities add chronic myeloid leukemia. When there is increase in the reticulocyte count, we call it hyperproliferative. It occurs in hemolytic anemia, whatever the cause, autoimmune, and hemoglobinopathies like thalassemia major, including in the hemolytic anemia, hereditary spherocytosis, glucose 6-phosphate dehydrogenase deficiency. All these are the peripheral blood. Also, we can divide anemia according to the size. The size, we take the mean corpuscular volume, and the units for mean corpuscular volume is femtoliter. So if it is a small RBC, we will see in the slides, we lab values, it's called normochromic. When it is large, more than 100 femtoliter, it is called macrocytic. And also, is it acute or chronic anemia? Usually, the patient in acute anemia hemodynamically unstable. How we judge that this patient hemodynamically unstable? When the patient is hypotensive, when the patient has tachycardia. These are reflecting that there is an acute blood loss. This blood loss is large. We can compare the complete blood picture CBC now with the patient had it 1 month ago. So if we see that the patient has the same low hemoglobin 1 month ago and now, this means that it is a chronic. But if 1 month ago it was 14 grams per deciliter and now it is 7, this means that there is an acute blood loss. And also looking for overt blood loss. This overt is opposite to occult. Occult مخفي, overt ظاهر. So looking for overt blood loss, as I told your colleague before you come, that the patient might have melena, might have hematemesis, might have hematuria. These are looking, we can see. The patient can bring us stool and we see it is tarry, dark stool. It can bring us a vomitus, and we can see that the vomitus is bloody. So is there an overt blood loss or not? What is the mean corpuscular volume? I just mentioned it. It is microcytic when there is decrease in the MCV, normocytic when it is normal, and macrocytic when it is increased. So we take the macrocytic anemia when the MCV is small. The causes of microcytic anemia is an iron deficiency anemia, thalassemia trait or thalassemia minor, anemia for chronic disease, and usually anemia for chronic disease is normochromic, normocytic, but in about 25% of anemia for chronic disease, it can be presented with microcytic, sideroblastic anemia, and inlet poisoning. So what are the lab findings in patients with iron deficiency anemia? It is a microcytic hypochromic. Let us use the pointer. Okay, thank you very much. What's your name? Raghat. Thank you very much, Raghat. So it is a macrocytic hypochromic. What we mean by hypochromic, that there is a low mean corpuscular hemoglobin and mean corpuscular hemoglobin concentration. These two RBC indices indicate it is hypochromia. And the low mean corpuscular volume, it means that it is microcytic. Hemoglobin level low, low serum ferritin, high iron binding capacity, and increase in the soluble transferrin receptors. As I watch you from your physiology lecture, you know now about the transferrin receptor. These are present on the precursor or in the bone marrow on the RBC precursor, the erythroblast. But when there is decrease in the iron, there is a shedding of these receptors into the circulation. So they are increased. And we call it soluble because we detect it in the peripheral blood. So increase in soluble transferrin receptor because there are no sufficient iron to saturate these receptors in the erythroblast. So what's the difference between serum ferritin and soluble? Both of them are important in diagnosis of iron deficiency anemia. Ferritin, it is an acute phase protein. So it is increased in any infection, even you have tonsillitis. So if the patient sometimes he is anemic but high serum ferritin, this is not normal, but it is due to the patient might have concurrent infection. So always, if you have discrepancy between the hemoglobin, low hemoglobin, and normal or high ferritin, think of infection. While soluble transferrin receptors do not affected by infection. So it is more dependable in diagnosing iron deficiency anemia than the serum ferritin. If you have any question, just raise your hand, please. And this slide is from Davidson, which is the textbook. Next year you are going to read it, in it. You can see in patient with iron deficiency anemia, mean corpuscular is reduced, serum iron reduced, total iron binding capacity decreased, serum ferritin reduced, soluble transferrin receptors, it is increased. Iron in the bone marrow is absent, iron in the erythrocyte is absent. Well, if we take anemia for chronic disease, the second column, you can see that the mean corpuscular volume low, normal, or normal. So it could be microcytic or normochromic. normocytic. The serum iron in both are reduced. But how we differentiate it, we can see that the serum ferritin is normal or raised in patients with anemia for chronic disease. And the soluble transferrin receptor is normal, while here is increased. So we can use the serum ferritin and soluble transferrin receptors to differentiate between anemia of a chronic disease and anemia, iron deficiency anemia, when both are presented as microcytic hypochromic. But if they are presented as normocytic normochromic, it is straightforward anemia for chronic disease. You can see here the patient is pale. This is the conjunctiva, and this is the sclera. We pull the lower eyelid by the doctor or examiner thumb, and we look to this pallor. We should not depend on the color of skin to diagnose pallor, because in the black people, the color cannot be pale because of the dark color, while depend on the mucous membrane. On the second slide, you can see the sclera. This is the white area, is jaundice. So once you see a patient with anemia in the upper slide, ask the patient to look upward and looking for the conjunctival mucous membrane. If you want to examine for the sclera, you pull the upper eyelid upward and ask the patient to look downward, so that we have a clear view for the sclera to see if there is a jaundice. So this jaundice means that there is a hemolysis, and then we can follow the patient. This is also another patient. You can see here are dilated, fragile blood vessels, and it occurs on the tongue, on the lips, and this is called hereditary hemorrhagic telangiectasia. This lesions are affecting the whole GI tract from the tongue to the rectum, and they are causing a bleeding. And this bleeding will lead to an iron deficiency anemia. So by examination, looking for the telangiectasia, pallor, and then in the face, looking for any telangiectasia. This is also this here. You can see the cells are, this is one is small. This one is larger. This is a small. So this is called variation in size. We call it anisocytosis. Variation in the size of RBC. This is small. This is larger. So there is anisocytosis. Also, there is a change in the shape. You can see here it is look like oval. Here it's look like a teardrop, مثل الدمعة. So when there is a change in the shape, we call it poikilocytosis. So there is anisocytosis, poikilocytosis. And you can see the RBC, usually it is about 70-75% hemoglobinized, like this one. Only in the center there is a small pallor. So this is a well hemoglobinized RBC, but this one is a hypochromic. So this hypochromic, and this is microcytic. So there is a microcytic hypochromic anemia. Also, we can see in the lower part of this slide, there is a cracking at the angle of the mouth. شوفوها الكراكينج ولدي. This is called angular stomatitis. It is usually occur in multi-nutritional deficiencies, not peculiarly in iron deficiency, but occur with patients with B12, vitamin B6. So it's a multi-nutritional, but it gives us an indication that it is an anemia due to nutritional cause, angular stomatitis. The other slide is that anyone can know what is it? These are the nail of patient with iron deficiency anemia, and it's called cholionychia. It is a spoon shape. So if you put a drop of water here, it is halter. If we put a drop of water on our nail, it will be split down. But here, because it is a spoon shape and it is particularly peculiar to iron deficiency anemia. So cholionicia. This is a slide from a real patient, one of my patients. You can see that there is anemia hemoglobin 10 gram per deciliter. And here you can see the flag. This is the complete blood picture in the lab. The lab give you L, low or high. Normal, there is no mention. So if you are not sure what is it, you can look for the flag. So it is anemia because of hemoglobin here, it is low. Then we will go for mean corpuscular volume, it is 73. The normal value is 8294 femtoliter. So it is low, 73. The MCH is 22, while the normal is 27 to 31. The MCHC is 30, also low. So this patient is anemic with microcytic here because of low MCV and hypochromic because of low MCH and MCHC. So this anemia, hypochromic, microcytic. We can find these in patient with iron deficiency anemia and patient with thalassemia. How we are going to help us to not differentiate it completely, but give us a clue that this is an iron deficiency anemia or this is thalassemia minor or thalassemia trait. We're looking for the RDW, this one, RDW. الRDW مختصر ل red cell distribution width. The RDW is 18.2 and the normal value is 11 to 15 and the flag is high. So there is increase in the RDW, which means that there are a lot of variation in the size of the RBC, very small, smaller. All of them are microcytic, but there are variation in the size. And this more in favor of iron deficiency anemia rather than thalassemia trait or thalassemia minor. This is an important to look for. Now we come to the normocytic anemia, which mainly occur in patients with chronic diseases like a chronic renal failure, rheumatoid arthritis, which the causes are anemia of renal failure, anemia of liver failure, endocrine disease like in adolescence and hypothyroidism, and hypogonadism, early disorder. These give us a normal size RBCs. About hemolysis, the hemolysis can occur inside the blood vessels, which is called intravascular, or it can occur in the reticuloendothelial organs, mainly the spleen and the liver. We call it extravascular. What is important for us as doctor to know, it is intravascular or extravascular. Intravascular usually more severe. Example of an intravascular is probably, I don't know whether you took malaria, falciparum malaria, cause severe intravascular hemolysis, and when it is associated with fever and there is a hemoglobinuria, it is called a black water fever, because the urine is black and there is a fever. The second important to know if it is an extravascular or intravascular. If it is an extravascular and the site of destruction is spleen, one of the options, one of the modalities of a treatment is removing the spleen, doing splenectomy, and we remove the site of the destruction like in patient with hereditary spherocytosis. When we remove the spleen, the RBC lifespan will be 120 days as normal, because they are not destroyed in the spleen. So when there is an RBC destruction, there is a release of hemoglobin in the circulation, which is toxic. The defense mechanism for it is haptoglobin combined to this free hemoglobin. When it is the haptoglobin finish and still there are free hemoglobin in the circulation, then it combined with albumin to give methalalbumin. Still, there is a free albumin, free hemoglobin in the circulation. Then it goes to the kidney. In the kidney, it first of all is deposited in the renal tubular cell as a hemosiderin. Excess of hemoglobin, then it will appear in the urine as a hemoglobinuria, and the color is dark. This is for the intravascular. For the extravascular, there is destruction of the RBCs in the reticuloendothelial system, and then there is increase in the unconjugated bilirubin. So we have two components for the diagnosis. There is increased production of the reticulocyte count. And we use the corrected reticulocyte count. And if we do a bone marrow, we see that there increase in the erythroid hyperplasia, the precursor of the RBC, increase in number so that to increase production of RBCs. And we have a red cell destruction. We have increase in the indirect bilirubin. We have increase in the lactic dehydrogenase, which is an enzyme, decrease in the haptoglobin, and also decrease in the hemopoxine. And there is a complex which is called hemopoxine complex. It's like the hemoglobin, and there is a hemoglobinuria. So in patients with hemolytic anemia, you will find elevation of the reticulocyte and bone marrow hyperplasia and evidence of RBC destruction. These are increase in the indirect bilirubin, increase in the lactic dehydrogenase, decrease in the haptoglobin and hemopoxine complex and hemoglobinuria. So investigation of a hemolytic anemia, peripheral smear is the most important initial investigation. What we mean by peripheral smear? We take a drop of blood, we put it on a slide, we spread it, and we stain it, and we examine under the microscope. What is the importance of looking for a patient with hemolytic anemia? We're looking for the shape of the RBC. If there are a lot of spherocytic RBCs, there are two possibilities. First of all is that it is hereditary spherocytosis or autoimmune hemolytic anemia. Both of them give peripheral smear spherocyte. We can see target cells, mainly we see it in thalassemia. We can see sickle cell in patients with sickle cell anemia. So peripheral smear gives us an idea, while the complete blood picture, we discuss it, does not give us all this information. Just give us hypochromic microcytic. But what are the morphology of RBC? We can get it from the peripheral smear. The second one is the Coombs test. The Coombs test with anti-IgG and anti-complement. The Coombs test give us idea that this is an autoimmune. So if the patient has hemolytic anemia, I will do Coombs test. If it is positive, I will not think of thalassemia. I will not think of hereditary spherocytosis. I'm not thinking of G6PD, because these are Coombs test negative. So I'm thinking of autoimmune hemolytic anemia. The autoimmune hemolytic anemia could be idiopathic or could be associated with other autoimmune diseases like systemic lupus erythematosus. So the Coombs test, if it is positive, then I'm thinking of autoimmune disease. If it is negative, Coombs test, I'm thinking of hemoglobinopathy. I will do hemoglobin electrophoresis to detect thalassemia or sickle cell. I will do G6PD enzyme to detect G6PD. Or I do the osmotic fragility test for the hereditary spherocytosis. So these two important investigations, smear, peripheral blood smear, and the Coombs test. This is also the slide from Davidson. In patient with hemolysis, whether intravascular or extravascular, there is decrease in the hemoglobin. There is increase in the unconjugated bilirubin. there is increase in the LDH lactic dehydrogenase, increase in the reticulocyte, and increase in the urinary urobilinogen. This is whether it is intravascular or extravascular. When there is a intravascular hemolysis, we have decrease in the haptoglobin, increase in methemalbumin, positive urinary hemosiderin, and hemoglobinuria. This is more because it is a more severe intravascular than the extravascular. Now we come to the macrocytic anemia. What we mean by macrocytic? When the size of the RBC is large, the MCV more than 100 femtoliter. Megaloblastic anemia, we find it in B12 folic acid deficiency or chemotherapeutic drugs, myelodysplastic syndrome, liver disease, hypothyroidism, or increase in the reticulocyte count. Reticulocyte has larger size than an RBC. So if there is a reticulocytosis, then the MCV will be increased by the. This is blood film showing that this is large one. How do I know that it is large? I compare it with this lymphocyte. This is the lymphocyte. You can see this one is larger than the lymphocyte. So it is a macrocyte. So there is a macrocytosis by comparing the RBC to the lymphocyte. And also, you can see this one is a large, so there is a macrocytosis. The second important finding on the peripheral blood film is hypersegmented neutrophil. Usually neutrophils has 3 to 5 lobes. When it is more than 5 lobes, we call it hypersegmented, and this occurs in vitamin B12 and folic acid deficiency. And you can see the macrocytic RBCs. This is the last slide. Thank you for your attendance. Really, I am pleased that you are so keen to attend, and thank you for your help. Thank you for your help. And if you have any questions, I am ready to answer. And how I stop? Thank you very much.